Good morning. I'm Britt Nicholson, the Senior Director for Development, and it's my pleasure to welcome all of you to the sixth in our seminar series, Answering the Call. Today's program is entitled Having a Healthy Fall. And of the 6 programs that we've had so far in this series, we have the largest number of registrants of any of the series, which is really an indication of the interest in this topic. A few housekeeping items, just to remind you that no microphones or video capabilities are needed to participate today. And at any point during the webinar, you may ask questions, and you can do it anonymously if you prefer. One of the advantages of attaching your name to a question is that if during this seminar we don't get a chance to answer the question in a live format, we can follow up with you with an answer by email. And later on, the webinar can be shared. It's being recorded, and we'll communicate with you with a shareable link that'll be provided after the event. One disclaimer that I'd like to go over at the very beginning, has happened since the beginning of this pandemic. Information changes rapidly, and all we have to do is just to think about the advice that we were given on masks at the beginning, where initially masks out in the open weren't necessary, and well, maybe masks were necessary, but only a surgical mask or an N95 cloth mask didn't work. And then we were told absolutely cloth masks do work if everybody's wearing them. So information changes rapidly. So things that you're hearing today are guidelines that are current as of today, but be aware, reading the newspaper, paying attention to reliable sources of information, that things can change. We're fortunate to have 3 extraordinarily talented panelists with us today. The first is Monique Tello, who's Director of Research and Academic Affairs and the Healthy Lifestyle Program within the Division of General Medicine here at MGH. We're also joined by Vandana Madhavan, who is a physician who is Clinical Director of Pediatric Infectious Disease and the Pediatric Hospital Medicine Program. She's also Director of the Pediatric Advanced Clerkship in the MassGeneral Hospital for Children. And finally, Patricia Simpson is a registered nurse who heads up the Emergency Preparedness Coordinating Program at MGH Chelsea, Revere, and the Charlestown Health Centers. And so, Monique, I'm going to turn the program over to you.
Thank you so much, Britt. So yeah, I am co-leader of a very determined group of primary care physicians who want to make a healthy lifestyle the foundation of the primary care that we provide to all of our patients. And we want to do that because we understand how important healthy lifestyle is to staying healthy. And it's true more now than ever in the era of COVID. And I'll tell you, when I opened up my email in March and read I was being redeployed to the inpatient surge wards, I was stressed. I was stressed and scared. And all of us, as we filed into work at the start of our shifts, we were stressed and scared. We relied not only on our personal protective equipment to keep safe and not get infected, and if we did get infected, to stay healthy, we relied on our self-care. And a number of us actually co-wrote a post for Harvard Health Blog in mid-April about this, 6 steps for self-care during the pandemic. And everything that we wrote then and everything that we practiced then for our own health is true now. And I'll just tell you what it is. It's not trying to keep it a secret. So number 1 was managing stress. So acknowledging that we were afraid, but also acknowledging how lucky we were and practicing gratitude on a regular basis. That kind of positive thinking or positive spin on things is really key to getting the stress levels down, the cortisol levels down, and that's going to help your immunity. Getting enough sleep. It's hard when you're stressed to sleep, but that's part of stress management, right? Is that you relax yourself so that you're able to sleep, is critical. Part of that is going to be regular physical activity. We know from tons of research that regular physical activity correlates with lower stress levels, lower blood pressure, better sleep. All of that is going to help us if we, God forbid, get sick. Nutrition. Can't emphasize this enough. We have mountains of studies on this. A plant-based diet, as much as possible, doesn't have to be entirely vegan, just as many plants as possible in your day is going to help. Again, it's anti-inflammatory, so it's going to help bring down levels of inflammation in your body, lower blood pressure. It's going to boost your immunity. We also have a lot of research on this. These are things that are within our control. COVID, outside of our control right now, but all of those things are within your control. In addition, connecting with others. So healthy social connection, the kind of connections that help you to feel relaxed, that help you to feel fortified, and that aren't draining. And we all know the relationships in our lives that are draining. We want to minimize that right now. Put the people on mute that you need to put on mute, unfriend them on Facebook, whatever. Get those stress levels down and connect with the people who give you strength. That's very important. And those are some of the key lifestyle factors to staying healthy. And if you do get sick, to not getting as sick. And we are relentless about this still. I think we had originally thought that, COVID, the surge would end and life would go somewhat back to normal. We're realizing now that was a sprint and this is a marathon. This is going to be ongoing. And so paying attention to those key lifestyle factors, the things that we can control, that's what I recommend to all of my patients when they come in and say, what else can I do? What else can I do to stay healthy during this time? In addition to all the basic social distancing measures, wearing masks when you're around others, hand hygiene and all of that, those lifestyle factors, those are very important, and I live it. I live it every day. And I want to see a healthy lifestyle become incorporated into the care that we provide to all of our patients every day. Every wellness visit, we should be asking people about their diet. We should be asking people about their activity levels, about their stress management, their social connections, their sleep. This should be very basic, and we should be able to offer the counseling and resources and interventions that people need in order to have a healthier lifestyle. And I'll be available for the Q&A for anybody that wants to know more. And I was allowed to do this. It's all in my book, Healthy Habits for Your Heart. And it's in all of the blog posts that I write for Harvard Health Blog on the topic. So you can see everything that I'm talking about, I've written about, and there's ample evidence behind it.
Great, so thank you so much. So as Dr. Nicholson mentioned, I wear a lot of different hats, and in those different roles, I've cared for children with COVID-19 as well as MISC, helped develop protocols for infection control, evaluation and treatment of COVID, and done a lot of education within pediatrics in the community regarding the latest updates. So I'm going to try to touch on a lot of the different things that I've been thinking about. I just have a few minutes here, so this is going to be very rapid fire, but happy to answer questions at the end of this session or afterward as well. And again, just want to reiterate that information is just evolving so rapidly. You'll be hearing that a lot of times during the next several minutes. So as we all know, the number of cases is really increasing. Just to put it into perspective before we go into some more details, as of August 25th, there were over 5.7 million cases of COVID-19 in the US and over 176,000 deaths. As of early this morning, the WHO was reporting 23.6 million cases worldwide and over 800,000 deaths. The initial numbers in the global pandemic show that approximately 2% of cases were in children. Typically defined as between 0 and 18, but that's varied. The American Academy of Pediatrics has compiled some state-level data, and as of August 20th, which is the last time that we had more comprehensive data, there were over 440,000 cases in children, which was 9.3% of all cases. And so I'll mention this again, but just finding the exact number of cases worldwide in adults, locally in children, all very difficult since, clearly testing availability has varied a lot. But so we're still learning a lot about exactly which children are going to be infected and their risk factors. I'm going to talk a little bit more about multisystem inflammatory syndrome in children associated with coronavirus, or MISC. That's gotten a lot of press as well. Initially, another name for it was PMIS, or Pediatric Multisystem Inflammatory Syndrome. But it began to be identified in Europe in mid-April, approximately 1 month after initial surges. The first reports from the UK, and then we had reports from France and Switzerland. And then about a month after that, in May, we started seeing reports in New York, and then the rest of the country. And what's been really challenging and fascinating and interesting about this, as we've learned so much, is that there's such a wide spectrum of illness that's encompassed within MISC. Children typically have fever, but they can have respiratory or GI or neurologic symptoms or rashes, conjunctivitis. And when we do laboratory evaluations, they have very severe elevations in a number of inflammatory markers. They can be very severely ill, presenting with shock, requiring very significant cardiac or ventilatory support. Some patients, including 2 that we've taken care of here at MGH, have required ECMO, or extracorporeal membrane oxygenation, which is basically like a heart-lung machine, but not in surgery. Some can present like Kawasaki disease, which is an unusual inflammatory process that is not common. And some have milder symptoms overall, but when we get laboratory studies done, they have very significant laboratory anomalies. All the confirmed cases, here in the U.S. have had evidence of prior infection with COVID-19 or significant exposure, with multiple family members having documented infection. But we're still, unsure, is this truly a later infectious process, or is this a post-inflammatory process where the body gets revved up from a pretty mild infection, but then, presents with this, 4 to 6 weeks later. Children, patients, but typically they've been children, although there have been some young 20-somethings as well that have been identified. But children are treated with different combinations of anti-inflammatory agents, steroids, intravenous immune globulin or antibody, or anakinra. Going into some numbers just to put this in perspective, because again, it gets, a lot of attention. But as of August 20th, the CDC was reporting 694 confirmed cases and 11 deaths, and that was among 42 states, New York City and DC. New York City has been reporting data separately from the rest of the state. Cases have ranged from infants to 20 years old, but the majority have been in children ranging from 1 to 14. And just to acknowledge the burden of COVID-19 infection in the US, more than 70% of the cases that have been reported to the CDC have been in Hispanic, Latino, or Black children. Coming a little bit more locally in terms of what we've seen here, as we know, our first surge of cases of COVID-19 and subsequent MIC was in the spring. But we do expect another surge, though potentially with fewer patients and over a longer period of time, depending on the exact degree of statewide interventions or mask wearing or social distancing, business restrictions, school opening. I'll be talking about school in just a moment. And so here, because of just all this evolving data, we're continuing to reevaluate, update our diagnostic and treatment protocols for both COVID-19 as well as MIC with a multidisciplinary group. There's infectious disease, rheumatology, hematology, pharmacy, primary care. And we also have a multidisciplinary daily meeting to review current cases to really make sure, because there's so much information, no one person can really stay on top of it all. I wanted to briefly mention a recent paper co-authored by Dr. Lael Jonker, Pediatric Pulmonology, that's gotten some recent press and attention, looking at patients seen here at MGHFC. There were 192 patients who were enrolled to have specimens obtained from various sites. These patients went up to age 22. 26% were positive for SARS-CoV-2, and 9% or 18 had MISC of those patients, although we've seen more patients than that for MISC. And interestingly, symptoms were non-specific. Only 51% had fever. And so I think just really emphasizing the really broad spectrum of presentation in children for both acute infection and for MISC. Interestingly, viral loads in the nasopharynx were higher in children in the first 2 days of symptoms, and younger children had lower levels of a specific receptor in the lungs, ACE2. And this is thought to be why that even though they might have higher loads of virus, we all know little kids are just in each other's faces and their families' faces, they're going to have higher viral loads due to the lower levels of receptor in the lungs. It's thought that that's why they don't have the same kind of triggering of an inflammatory response and as significant lung disease as adults do. And so transitioning to what I think, people are really interested in. So what are all the considerations that have to be taken into account when we think about what is happening with school and what are we recommending for safe care for patients and families? And again, it's important to remember that unlike, pretty much all other respiratory viral infections, especially influenza, children are far less likely to develop severe disease, especially disease requiring hospitalization or ICU level support. The number of cases remains difficult to estimate because, kids aren't as sick, they're not presenting for care, they're not getting tested. And especially in the early days of the pandemic, they just weren't meeting criteria for testing. So calculating the percentage of children who truly have infections, severe complications is not possible, but it's very likely that we have a very large pool of infections and a smaller percentage of severe complications. We do know that children with underlying medical issues, including respiratory or cardiac disease, immunodeficiency, are more likely to have complications, but again, just not in the same numbers that we see with influenza. Very young infants may be at higher risk. There have been some studies, that have come out, but really case reports and case series, just a handful of babies in each paper. And we would expect higher rates just given the rates of infection in pregnant women. So there's clearly something different about this that doesn't trigger the same response in children, infants and children. But it's been difficult to identify specific risk factors because of low numbers. We're getting a lot of evolving information about the role of children in transmission. Children are typically infected by adults in their households and are less likely to transmit to others, even though, as we've seen in some papers, it seems that they could have higher viral loads. Although here in the U.S., it's a little bit difficult to know. We had early school closures in a lot of areas. So that led to lower than normal group activities, both during the school year as well as this summer. A lot of camps are closed. Camps that are open have smaller numbers of kids. So they just have lots less mixing of children than we typically do. So we have less information about child-to-child transmission. A very recent study from Germany that was just discussed the last couple of days showed that there was rare child-to-child transmission in the school setting. But again, there was very quick identification of cases in the community. The cases were isolated, contacts were traced very effectively. So again, fewer opportunities for that child-to-child transmission. So it's hard this is what's making it so difficult, is all this information is coming out. It's very difficult to say, well, what happened in country X is good for country Y, because there's so many variables to consider. We also are learning more about the rate of co-infections. Early studies, including some data here at MGH, have shown that they weren't as common. However, we haven't seen COVID-19 during the peak respiratory viral season, and so we don't really know what's going to happen when we start seeing influenza. We do know that people looking at studies from China and Singapore early on, doing really detailed contact tracing and seeing when people were more likely to transmit. People are more likely to transmit infections between 2 days prior to onset of symptoms and up to 5 to 7 days after onset. So this is why recommendations for return to work or school after illness has changed often and significantly. But so longer periods of isolation aren't required. But again, because of this pre-symptomatic transmission, it becomes all the more important to think about the other measures that we're putting into place. It's not enough just for sick people to self-isolate. And so then thinking about school in the next, couple of minutes, just other sort of non-medical things to think about. Online, school isn't as effective for younger children. Socialization is so important. And other benefits of in-person school include meals, mental health resources, identification of struggling families. And so that's why they're just evolving. I'm not going to go into details because, again, they're evolving so quickly. But, prioritization of in-person school for younger children and those at risk due to lack of resources at home or additional learning challenges are so important. And so while schools are ensuring safe learning environments, thinking about appropriate distancing and room capacities, ensuring appropriate ventilation, thinking about eating, and thinking about specific activities. For example, singing or playing wind instruments is very different than playing stringed instruments far apart, or, football and contact sports are very different than, individual runners. It's really important to think about, those, but it's also important to think about what we can do. So to iterate again, we know that masks work. After MassGeneral Brigham instituted implementation of, universal mask policy, there weren't cases of hospital-acquired infections. People have heard about the cases of the hairstylist in Kansas City who worked while sick with COVID-19 but wore masks and didn't transmit infection to any of their clients. Hand hygiene works, physical distancing works. So it's just important to really model all of this and practice and teach our children and emphasize that we're all in this together. And this is what we're all doing for each other, not putting the burden of mask wearing and hand hygiene on them to protect their teachers and protect their grandparents. It's what we're all doing to protect each other and those that we love. And important to acknowledge that it's hard for children, but also that we can find silver linings, that they can't have in-person play dates, but they can make fun cards for each other and bake cupcakes that can be delivered at a safe distance on a doorstep, and so it's just really important. And I know there were questions about vaccines. I just want to finish mentioning that we already know that there's been decreased vaccination rates in children for routine vaccinations since the onset of the pandemic. People are concerned about coming into the hospital or any medical setting into the clinic as well. And so it's just really important to ensure that children are up to date with their routine immunizations and seasonal influenza vaccine when it's available. While we're focused on COVID-19, it can be easy to forget that a cough could be due to measles or pertussis, especially with lower immunization rates. So again, there are no easy answers to all of this, but we're all in this together. We're all learning about this together, and I'm happy to answer questions. So I want to hand off to Patricia Simpson. Thank you.
Hi, thank you so much. It's an honor to be here. Thank you. I'm learning so much. I am an emergency preparedness coordinator for MGH, Chelsea, Charlestown, and Revere. As my colleagues, we have wear many hats. So pre-COVID, post-COVID, we're doing different things. Pre-COVID, I was the emergency preparedness coordinator, and I would be the liaison for MGH to the hospital, and then do a lot of training with staff and the community and CPR and fit testing. I was also the senior wellness coordinator for a group of seniors that meet twice monthly, and they do yoga and qigong and strength training, and we do intergenerational fun things, like we had salsa dancing on the beach with the youth zone, which with some children the last 2 years. Hopefully we can do that again someday. And I'm also a co-leader of a support group for caregivers of people with dementia. The last thing that I do is that I supervise a jobs for the MGH Jobs for Youth program, which is this wonderful opportunity for students in different communities to actually work in the health center and experience what it's like to be in the health center. So I coordinate that program here in the summertime, and we usually have 5 to 7 students from the Chelsea High School that we place in different departments, and we give them a wonderful experience where they get to learn what it's like to be in the healthcare system, as well as we mentor them in resume building, application for college. Some of our students have gone on to nursing school and college, and many of them have been from families where they're the first to go to college. So it's been really fun and an honor and a privilege to work with them. When COVID hit, MGH leadership were amazing. They immediately responded by activating all of the tools that we can to help our communities. One of the things that they directed and that we did was at MGH Chelsea, we repurposed our health center. It was a regular health center with all the services, and we repurposed it into being just a testing center. It's called a RIC, Respiratory Infection Clinic. We had in 1 week, we had to repurpose our health center, equipment, build walls, move stuff, bring staff in, have staff go home to work remotely. It was a lot going on in 1 week. MGH was amazing in their response. We got it up and running immediately. My role was to sit on the incident command team with the command team here at the health center who worked in conjunction with MGH leadership to activate and have an effective clinic. And my job was sitting there under the guidance of Jeanette McWilliams, who's our administrative director, who's an amazing leader, who ran these daily meetings. And I sat in the meeting so that I could communicate with the community, so that I can see what's going on here and see what needs to be communicated out to push the information out to the community. At the same time, the city of Chelsea activated the Chelsea Pandemic Response Team, which was a group of 70 of the leaders and some residents from the city of Chelsea. The city manager was on the team, superintendent of schools, myself representing MGH Chelsea, all the organizations, faith communities, senior housing, school, everyone was represented. And we met every day on a call at 4 p.m. for half an hour. And we just gave our updates. It wasn't problem solving, but it was updates on what's happening. At the end of that call every day, one of the faith leaders, because all the faith community was on the call, would lead us in a prayer at the end of that meeting every day. And we met every day for 3 months. We're meeting now every week, but we're ready to ramp up again if we need to. All the information we collected, we have kept virtually on an Airtable, and so we can activate our resources as we move forward. Our partnerships have been enhanced, and unbelievable the help we're getting and the support that we're getting from other organizations and people from all over the place. It's been unbelievably fabulous. You can hear the train going by behind me, so sorry about that. So we've been pushing out information through the Chelsea Pandemic team. So all of the organizations on the team have social media, have the ways that they push out the information. A lot of it's through religious, a lot of the churches and the religious leaders, they're pushing out a lot of information. We're doing a lot of that through using the platform of the Chelsea Pandemic team. We've also, to get out information, we are doing a lot of PSAs, public service announcements, and like Britt and like we're saying, things change all the time. So in the beginning, we're talking about what are the signs and symptoms of COVID. Now we're focusing on mental health. There's a lot of mental health issues, as we know, all across not just in the city of Chelsea, but all over the world right now. There's a lot of mental health challenges. And so we're trying to address that and incorporate mental health into our everyday communication tools. Chelsea's very challenged because we have a lot of health inequalities. We have a lot of housing density and poverty, language isolation. We have a lot of industrial pollution and a high rate of respiratory illness. So we have a lot of challenges ahead of us. It's been amazing, all of the partnerships that are developing, and the leadership at MGH has been amazing in pushing and helping us to educate and do the best we can to increase the health equity of our communities, and especially focusing on Chelsea. One of the things I just want to say that's really a very big challenge is the digital divide. Many of our residents here in Chelsea don't have access to Wi-Fi nor the tools to do so. And now with the focus and the refocus on telehealth, this has been a really big challenge for us, and we're taking it very seriously. We just piloted a program. We identified 33 of our mental health patients that needed the care the most, that we couldn't have fall through the cracks. We have given them iPads. We've identified who they are, and we've actually hired students, young folks from the community, to do one-on-one training with them. We have increased, so we have 33 new opportunities of patients to get health care that were not getting it before. And I just got a letter across my desk that one of the therapists wrote a little thing saying that her patient who has serious medical issues and severe depression was coming in once a week for a group therapy and could no longer because she lives alone in an elderly complex. And we gave her one of these iPads, and she had her first telehealth meeting, and she was crying, and she said it's the best thing that ever happened to her. And which is like just such, and it's a simple story, but now she can get her information through Patient Gateway. She can see her doctors, she can be connected, and we need to push that more to get everybody connected and up and running with healthcare and with the opportunities and the hope that we can offer them. Thank you.
Well, thanks very much. And you won't be surprised that we've got a number of questions, and I'm going to get right to them. So, Vandana, I'm going to start with you. This is a question I'm sure you've heard from others before. It's, I have a new grandchild born at 34 weeks, currently in the NICU in San Francisco, but thankfully doing well. My husband and I plan to fly out September 22nd. We are 64 and we are taking all the precautions flying. When do you think it's okay to hold the baby? My daughter's due date was September 29th. Thank you for any and all the advice that you might be able to give us.
Of course. So first of all, congratulations. That's wonderful news. This is, again, I have to say this with the caveat that, that's still, it's almost a month away and recommendations could change. But I think, if you've been, staying at home, minimizing, contact, and when you've been out getting groceries or taking walks, et cetera, been wearing a mask, et cetera, and, are safe, I think additional, precautions would be to get testing, right before. So if you've been, staying at home, minimizing your risk, getting tested, and then the travel itself is obviously, a period of time where, there are a lot more unknowns inserted into the equation. But I think after you get there, I realize, like, after you travel, waiting another, potential, 1 to 2 weeks until you can hold a baby is going to be functional. But I would say, like, making sure that you continue to wear a mask. I know you'd want to hold your grandchild and kiss your grandchild, but wearing a mask, et cetera, because you never know about what you might have been exposed to during travel. Because I think I'm most worried about that, that piece. But I think being at home here, staying safe, and then going there and staying safe, should be fine. But again, making sure you comply with travel restrictions that are in place in September.
So Monique, this one's for you. Thank you so much for all of the tips in terms of handling stress. In terms of recognizing stress in family members, especially children, they won't necessarily tell us that they're stressed. What should we be looking for?
Yeah, I feel this very much. So our youngest, our 8-year-old daughter, has been incredibly stressed throughout this entire pandemic. And that has manifested as a lot of outbursts. So I think with children, and Vandana can comment on this as well, but in children, you're going to probably see some regression, tantrums. You're going to see that stress come out in other ways. They're not going to be able to look at you and say, Mom, I'm so stressed out about the pandemic, or I was worried about you getting sick while you were going to the hospital. But those things are true, and it comes out when she's, refusing to do something very simple and straightforward, like brush her teeth at night, or she throws a temper tantrum over something that normally wouldn't upset her at all. And so what we did in that case, we did seek some help. So we didn't necessarily tell her, oh, you need to go talk to a therapist. We went to the pediatrician and described what we were seeing, and they have helped counsel us on how to help her get through this time. Like, how can we be supportive? And I think that's going to be true on the adult side as well. So when I have a patient who comes in and says that they have a family member who, is suffering from some kind of stress or mental health issue, and they want to know how can they force that family member to go get help. You know, I usually counsel them, listen, I think what you need to do is get help for you so that you can be counseled on how to support your family member, how to better be there for them and understand what they're going to need. Because in the end, that social support piece is going to be critically important. And that's something that only you as the loved one is going to be able to provide. So that's sort of, you know, the very personal take I have on this, and also the take I have on it as a primary care physician.
Great, thanks very much. So Vandana, here's again a question that you've probably gotten before. I am just wondering what MGH's take is on using hydroxychloroquine on COVID patients. There has been so much confusion. I'd appreciate your clarification. And again, thank you so much for this webinar. It's so informative and so helpful.
No, absolutely. Yes, like I said, there's a lot of information out there, not all of it coming through, you know, scientific sources. Hydroxychloroquine is still, you know, on a list of things we might consider, but it's not being universally recommended for patients. I will say that on the pediatric side, we've had very few patients who've been sick enough to warrant any treatments for acute COVID-19 infection. Sorry, someone just opened my door. So we haven't really addressed that, but on an overall level, it's not, you know, it's not something where we're saying everyone should be on it. It should be used right away. You know, there are definitely other treatments that are considered before, and I think Monique can address that as well as taking care of our bigger patients.
Yeah, I'll just throw out that I was a co-author along with 19 of our, well, I guess it was 19 of us total. We call ourselves the COVID-19. 18 of my MGH colleagues, we co-wrote an op-ed on this exact topic for Newsweek that was just published very, very recently. And I'm trying to pull it up so that I can give you guys the date. But I was very proud of this piece, and it was 18 very highly educated, experienced physicians and a nurse practitioner who wrote this. It was published on August 20th. It's called Coming Clean About Hydroxychloroquine, where we go through all of the evidence and all of the reasoning behind why we don't recommend the use of hydroxychloroquine for COVID-19, and really nobody who follows evidence-based medicine does. There's really not been any randomized clinical trials that show that it's useful, and there's been several that show that it's not. So it also has risks, serious risks, including cardiac arrhythmia. And that is something that we have seen. As a matter of fact, early on in the pandemic, when I was working on the inpatient surge wards, we had to discharge patients with the Xiopatch monitor because they seem to be going into cardiac arrhythmias at an unusually high rate. And we still don't know if that's because of COVID or because of all the hydroxychloroquine that was going around. And those trials were actually stopped at our hospital because of the risks with very little benefit. So I can say with surety, we're just not using it. We don't see the evidence for it. If a big, huge trial comes along and shows some benefit, I'm sure we would reconsider, but to date, there's been several that have not shown a benefit.
Patricia, this one's for you. It says, I can't imagine when you were first given the job as Emergency Preparedness Coordinator that you had any idea that this is something that you would be facing. Did you feel prepared for the role that you had to undertake?
Yes, thank you. I mean, who would have imagined that it would be like this? But I have got to say that Dr. Paul Bidinger, who is our emergency preparedness guru for MGH, I've done many trainings with him, and we've done a lot of trainings and tabletops and thinking about sort of like this. We didn't think it was going to be this bad, but we do feel we were prepared. There's challenges, obviously, and there's a learning curve, obviously. But I think MGH, we were in such a good position to tackle this that I feel very grateful that we were prepared.
So this next one, I think, is both for you, Monique, and Vandana. It's a multi-part question, so and it has both a pediatric and an adult component to it. So one, what is your advice for the flu shot in terms of should I get it early? Should I get it later? And should I think about getting revaccinated during the season? And the second part is, I know it's just a prediction and you're using your best judgment, but what do you think the prospects are for the flu season coming up?
We're playing a game of chicken here. Who's going to go
Yeah.
first? All right. So I'm getting this question a lot clinically. Seriously, I think I was asked about 3 times today by patients, when should I get a flu shot? And I'm erring on the side of caution. I'm saying go ahead and get it now. If it's available now, go ahead and get the flu shot, because we don't know if we're going to be experiencing an early flu season or a late flu season, but we do know that the intersection of the flu season with COVID is not going to be a good thing. So I'm advising people to go ahead and get it. Whether or not people should get a booster shot in the midst of the season, I'm not sure that there are guidelines out on that. There's none so far at MGH as far as the primary care guidelines that we follow. I'm sure that's going to be coming, and certainly I'm going to ask for them because of all the questions that have been coming out on this. I'm certainly having my kids vaccinated for the flu as soon as possible, just to keep them safe. They are going to be doing school remotely. That it was something that we opted for, even though we had the option to do hybrid. There's a touchy subject, and one that I'm sure we could all talk about forever. It's a tricky subject. I'm worried about the kids and kids being more infectious than we think. I am. I think there's enough evidence out there that there's a question mark on it. And I don't like the idea of putting my kids in a real life experiment. I just think it's unwise. I know that most physicians I know disagree with me on this and feel that we have the protective measures in place and the education for the teachers who are going to be monitoring our kids during the school day to keep them safe. I also know that the teachers themselves are very reluctant to get into this, and they don't really want to be part of this experiment either. And so for that reason, knowing that it's all a big question mark, really, I'm keeping my kids home.
Just want to follow up on the flu vaccine. I also agree. PD group practice here, my primary care practice, we just got flu vaccine doses here. So we are, offering them to any and all, children who have them. In pediatrics, children who are 8 and under who've never received influenza vaccine do need 2 doses, but it's not a booster dose. It's just that first time they get it, they need 2 doses to achieve immunity. But we have no idea when it's going to be here. Travel patterns are very different this year. So we don't know when we're going to start seeing influenza. We don't know how influenza is going to look along with COVID-19 in terms of presentation. So best to be vaccinated as early as possible. We also know about supply chains that are going to happen. So if you want to wait later, we might not have the flu vaccine available. So if it's there and you're available, I was just talking with pediatric leadership earlier today about getting ED patients vaccinated when they come in for something else, or, emphasizing vaccination doesn't have to come through the primary care setting alone, but it's so important that if someone is touching the health system in person and not virtually, trying to get them vaccinated to really increase our rates as much as possible.
So I think we've got time for one more question here. And Patricia, I'm going to direct this one to you. Several people have come in with the question. He said, what is MGH doing to prepare for a second surge? And are you concerned about the burnout on the care teams?
So MGH is preparing in that we're keeping the RIC here. We are continuing to support our RIC and our testing. We are doing a lot of vigilant testing in the community and through all the communities, and MGH is not dropping the ball. We're putting all our energy into keeping on top of this. Burnout has been a concern, and that's mental health issues for everyone. And so MGH has been amazing. Our behavioral health staff here at the Chelsea Health Center, they're offering yoga, virtual yoga, relaxation. We're having coffee hours, happy hours. MGH, we have employee assistant program where they have having lots of availability of support. So I feel like there is some burnout, and I think I know all of our directors are telling us take vacations now, get some rest, because we've all been working nonstop. So they're encouraging us take a break, take a 3-day weekend, take time to regenerate. So it is an issue. It is a worry, and it is on our radar, and we are actively addressing it.
Well, I'd like to thank all three of our panelists for a terrific job, incredibly informative. I'd like to thank all of you who have attended today, and to thank you for your support of the hospital. And I'd like to leave you with one message. One of the things that was mentioned on the webinar today was the fact that given the care that's been taken in terms of distancing and masks and hand hygiene in the hospital, we haven't had any documented cases of a transmission of the COVID virus, in the hospital. The MGH is here to help. We're here to treat, and I want to assure you that it is absolutely a safe environment. So, again, thank you for joining us, and always be safe.